Week 6, everyone. Hi. Um, so this week we're going to talk about evidence-based public health practice or evidence-based practice, EVP, EBPH, as in public health, or EVM, evidence-based medicine, analogous but a little different. We'll talk about that, and I also want to say that evidence-based evidence. People say that all the time. It just rolls off the tongue so easily. Actually, being evidence-based is really hard, and it takes it's a practice that takes a lot of rigor, a lot of cycles of efforts. I mean, CQI is one way, but it's not an easy thing to do. Being data driven, being data based is really hard to do. So I just want you to keep that in mind as you say evidence based. Like, what does it actually mean? So we're going to talk about some the readings you have this week. Is they're all very good. There's some that are longer than others, but these are very important, well-known articles for you to read. At the least, skim it so that you know what's in there. So, Frieden article, this is like, I know a lot of you have seen this, the pyramid structure or the ecological model, the concentric circles going from the one-on-one intervention to, socioeconomic, the, population level, infrastructure level interventions. So it's a really not long, but it's a really important and informative article that I recommend highly that you read. And it talks, of course, about the importance of having data and how you make data-based decisions on what level of intervention to whom and when, and the level, the size of impact you will have depending on what level in the pyramid and what kind of data. So evidence-based, what the definition of it, it means it is a process by which healthcare, well, in this case, healthcare providers or public health providers know how to find, critically appraise, and use the best evidence. So in terms of the means, like what is being used for this intervention, efficacy, does it work, versus effectiveness, how well does it work? Two different things. Strengths, weaknesses or limits, any reservations, and why? What are the side effects? So all those things are informed by evidence-based practice. And why. Health or healthcare delivery is filled with uncertainty, and many questions arise in everyday practice, right? So there are a lot of things that we do sort of because it's the way we've been doing things, or, this is not broken yet, so I'm just going to keep on going. Often these are not evidence-based. Or when you say evidence-based for this particular population, people also tend to, talk about data that like, for example, let's keep going with this diabetes example. Just because it's diabetes evidence doesn't mean it's your population, your program is evidence-based, depending on what race, racial, ethnic group we're talking about, age group, income level, education level, urban or rural settings. All those are part of what makes it evidence-based. So often we do not practice evidence-based practice. And what kind of guidance would be most helpful to the population? Again, this is this particular slide is from public healthcare practice perspective, but it's analogous for all health and public health and healthcare. Evidence to support best practice is constantly changing. So that's another difficulty, right? So what we use, and this is most apparent, and we can caricature it from nutritional science. Like, all of a sudden coffee was like the best thing you can put in your body, and then all of a sudden coffee was carcinogenic, and then coffee was good again, right? So things change all the time. So being evidence-based, the difficulty of being evidence-based is at another dimension because of this changing nature. And evidence is created or being built every day, right? So that's why. The reading by Brownson, Fielding, and Malon, it's a really comprehensive, I mean, it's like 30 pages, but you know, it's really kind of like a textbook chapter. So I really encourage you guys to read that. And in some of the graphics here in this deck is from that article. So decision making happens in the intersection of, you know, best having or, you know, finding best available research evidence, and that is customized into onto your population's specific characteristics and needs and values and any other preferences, and also based on resources, including the practitioner expertise in the team that you got. So in other words, you know, decision making of, you know, which evidence, how you would use the evidence, not which, how you would use the evidence in your practice is really determined by all these external factors. Key characteristics of evidence-based public health. I'm just going to say EBPH from now on. The tenets is 1, making decisions based on evidence. We're going to memorize this line by the end of this lecture. And 2, using data and information systems systematically as opposed to randomly and sporadically. 3, applying program planning framework. So there's actual theoretical frameworks for the planning, not just the actual intervention, the fidelity of the intervention itself. 4, engaging the community in decision making from the beginning to the end. That's like possibly the most important thing here, because it's really context-based, context-dependent, and also it's really for the community. You know, we are applying this EBPH on our programs for the community, so they need to be engaged through the decision-making process the entire time. 5th, conducting sound evaluation. So, you know, once we have program evidence, and then the need, and then there's a program idea. So you design it, remember logic model, we do all that, and then we do the program, we implement the program through the program planning frameworks, and getting the community involved. And at the end, you evaluate. Like there's a whole set of evaluation theories, right, for sound and robust evaluation. And then disseminating, so not ending it there, but giving back to the community their data. It's their data and their program, the outcome, the evidence, the data that you gather from the program, it, you know, belong to them. So you give it back, disseminating what is learned. And then it's a cycle. And then after that, and you go through the cycle of like improving. So this is kind of like CQI, but not like in a PDSA way, but like in a much bigger circumstance. So, you know, you continue this cycle of finding evidence, matching with the needs you have, run the program, evaluate, make improvement, do it again, all over. Scientific methods in the 4 steps. So some in different words, observation and description of phenomenon or group like a phenomenon or, you know, group of phenomena. So what's happening? You describe the problem. And I think we did something like that with your fishbone, right? You know, these are all very analogous. It's just the matter of scale and, you know, who's involved. And then formulation of hypothesis. So you're going to have a hypothesis, that's your aim statement, right? To explain the phenomena. So, you know, if we apply X to Y, we're going to get Z. And there's like a, you know, the whole pathway that you may, you know, hypothesize and, you know, formulate it out. And then using the hypothesis to predict the existence of other phenomena. So, you know, so having this one hypothesis and solving that problem or trying to solve the problem, you know, will link the other. So then it becomes a family of, you know, hypotheses and phenomena that you're working on. And then performance of the experimental tests on the predictions by several independent experimenters. So, you know, it's not just one group, right? So, you know, in the scientific evidence making involves not just one study, one single study that says, oh, this is beneficial or not. There's a bunch of other, you know, similar settings, not the same, by different experimenters and different, slightly different family of hypotheses, happening together to build a set of scientific methods and then outcomes. So then you build evidence. So, and there are different forms of evidence. Let's define evidence in public health specifically. Evidence is some form of data, including epidemiologic data. They tend to be quantitative, like, mortality, morbidity, incidence, all those you've seen again through COVID, right? Those, and results of program or policy evaluation. And there are also qualitative data, just as important to triangulate your outcome and triangulate with your quantitative data for uses in making judgments of or decisions. So again, it's a cycle of observation, theorizing, experiment, see what happened, what came out of the experiment, observation again, theorizing. So it's a cycle. So there are different types of, different forms of evidence. Some are more objective. I'm not going to say better or worse. They are different. There's a use for each kind here, and often they are used together and in tandem, in concert, to corroborate the others. So more objective ones are like, scientific literature and systematic reviews that have, big enough sample size and, small enough standard error, blah, blah. Scientific literature in one or more journal articles, as opposed to like lots and lots. So again, more evidence built, more verification, more corroboration makes the scientific evidence more objective. I hope that's obvious to you. And then there's a public health surveillance data. It's not necessarily systematic reviews, but the surveillance data, when we have big enough data set, that also becomes, like the more data you have, the more objective it becomes. That's evidence. Surveillance data, like tuberculosis, HIV, COVID. As we know, we learned a lot from the surveillance data, not only about COVID virus, right? It's more about population health. And then program evaluation, again, there are so many different qualities and levels and kinds of evaluation, but evaluations absolutely is a form of evidence. And there's qualitative data by community members and other stakeholders. And there's media marketing data, and those also, the bigger the data set becomes, the more objective, more robust of evidence it becomes. And then word of mouth, personal experience, we call it anecdotal. They're subjective. They're not as scientifically robust, but those are not to be discarded. They are a form. They're forms of evidence. And in the Brownson article, this table, there's a table, types of scientific evidence. So type 1, type 2, type 3. So there are things that are, like the most objectively done, systematic reviews, and it's gone through the clinical control, trial, a randomized control trial. So example, like smoking causes lung cancer. We use the word cause here, like there's a causal pathway, smoking, lung cancer. No two ways about it, right? So we have a lot of these types of evidence, type 1 evidence that we have in the recent history, funded, encouraged. So we have those. So it's really like something that needs to be done, like stop smoking. Like there's no one arguing with that statement from the medical and public health standpoint, right? So there's that kind. Type 2 evidence is, there's less of it, but it's really, it describes the relative impact of specific intervention that do or do not improve health. So it's more observational. We've seen observational studies, not, randomized control trial. The more observation studies, the more evidence like that you have, more type 2 evidence you have, the stronger your claim will become. So an example would be like price increases with the targeted media campaign, reduce smoking rates. So this is like, probably like a lot of our work will fall into. Our work meaning like public health programs. There's not one program, for example, to encourage smoking cessation. There's so many, and that's where the Friedman article comes in, right? In the pyramid, what level of intervention, like what kind of intervention, like what outcome of the smoking cessation and lung cancer are we looking at? There's a whole slew of of options, from like access to cigarettes all the way to like cancer treatment, right? Lung cancer treatment. So type 2 evidence, mostly observational. There's less of this still in our literature, but way more than type 3 evidence, which is this. We have least of this. This is the information on the adaptation and translation of an effective intervention in of itself. So we call that in academia among researchers, implementation science or dissemination science. So not the fact that smoking causes lung cancer, but what program versus the other, like X program versus X prime program, which is more effective, depending on what planning framework we use, implementation methodology, implementation science. So that is a whole set of evidence that that really needs to be developed more. That's really, so an example of that would be in the smoking series of example, understanding the political challenges of price increases or targeting media messages to particular audience segments. So not comparing apples to apples. So not this particular intervention that worked in certain state, certain city, at a certain under a certain political leader, does that work in other settings? Is this generalizable? Is this like, is the trial of this program in other location possible? So that's about not the actual theory of disease or the program effectiveness. It's about the implementation in and of itself. So those are the 3 levels of evidence the article talks about. And when it comes to type 2 evidence, we're looking at different typologies, like different categories of interventions by the levels of scientific evidence. So, if you have a lot of evidence, if you have enough, if you have promising evidence, or if it's like a totally brand new and the evidence is just emerging, how, like, what type of interventions would go with this, different levels of different types of scientific different levels of scientific evidence. So the article summarizes it really nicely. So I really encourage you to read that article. And when it comes to type 3 evidence, from a couple of slides back, the context, right? So like, like implementation science, like, this particular program that worked in one place, does it work in the other? And these are the types, the categories of domains, meaning like context, like an individual, like are we talking like the people that we're implementing this program for, right? And then the interpersonal, not just the individual who's at the program, but how does this person's immediate social context different from the other program that was successful or not successful. And then the people who run the program, the organization, like organization A in New York City ran this, and on a certain population that worked well. But this organization B in New Jersey, Central Jersey, different organizations. So what, like, staff composition, staff expertise, their dynamics, the physical infrastructure of the organization, where is it located, like how, and the organization culture, level of trust, all those things. So on and so forth, all the way to political and ideology of this location, the city that this program is being implemented. So these are like, and think of it again as like a concentric circle of ecological model, overlapping domains of type 3 evidence, and how what are some of the things one needs to be mindful of in implementing a certain evidence-based program. And then there's like the whole different set of like, analogous, but different set of evidence-based medicine. There's a whole rating system, and in terms of like the robustness of evidence. I'm not going to read through it. There's citation, you can go take a look. I don't, this reading is not part of your reading this week. And then there's also in terms of the individual studies, like, the published articles, what level of strength of what strength level of evidence there is. But then again, like, so in the EBM, evidence-based medicine, level A, the best gold standard is like the randomized control trial. We hear that, and we hear that in public health. How are they different? EBM and EBPH, they are very analogous. There are a lot of similar things, but they're also different things in terms of like, medicine is like, it's a clinical science, medical professionals, as opposed to public health. Public health is an applied field, and there are people come from different disciplines and also interdisciplinary programs. So the way we talk about evidence or evidence building is very different. It can be very different. And also, the randomized control trial, there's an ethic. It's just sometimes not possible to do it in a public health practice. It's also, there's, it poses also ethical issues. If there's a program that we know works, how are we going to withhold it from some other, some control people, control group, to give them placebo? And that's withholding programs that would actually benefit them, right? So, and there's the cost implication. It's very expensive. It takes a long time. Does this even make sense to be doing it? So there's that difference. Also, is RCT the only acceptable way to gather robust public health evidence? No. RCT is gold standard for EBM. Still, for example, COVID vaccine went through, controlled trials, right? We do that, but not for everything. And it's definitely limited in public health, but also the big data, like that I talked about in the last week's lecture. Big data enables us to not have to rely on randomized controlled trials for the most acceptable evidence. Evidence-based public health is greatly enhanced by observational studies. So, by nature of public health being public health, the two different standards of, what's more robust as an evidence is just different. And about the big data. So, real world data, real world evidence, there's even an acronym for it. It's like a thing now, really, for FDA. It is like, Food and Drug Administration, they approve like drugs and stuff, right? So RCT isn't the only one. We have a lot of data that are not randomized controlled trial, but when we have a lot of data, it mimics randomization of the population. So we've got the EMR data, we've got like all the big data we talked about last week, that informs also healthcare, medical decisions. So this is also why there's like this level of evidence and all that, really to put it in a tabulated form is not necessarily the way to go. Things are, like I said in the beginning of this lecture, evidence is changing by the day. So that's something important to keep in mind. Who uses EBPH? Obviously public health practitioners, executive level, management, leadership, and also policy. Program development, program dissemination is really important, as policy dissemination through policy making is important. And also stakeholders who are affected by the intervention. That's like, runs a whole gamut of, levels, end users to influencers of the end users to payers, funders, policymakers, and saboteurs. Saboteurs are people who would be competitors to this program, who would be hurt by this program being successful. So for example, something like sugar sweetened beverage industry, right? So these are all the stakeholders. They use evidence-based public health practice as well to market their products and argue against the other side. And of course, researchers on population health issues. They're the ones who help create evidence for public health. So to circle this training approach for EBPH, community. So community assessment happens. We learned that in PU 612. First, you assess the needs and the assets of the community. You quantify the issue. You identify what issue and then quantify the problem at hand. And then you develop concise statement. That's the problem statement that you guys have worked on. And you determine what is known through the scientific literature as the best fit program. So again, here evidence isn't just about the problem, like say diabetes itself, but where is it's being implemented and to what population and what degree, how much money, how long, all of the the contextual factors that make the implementation science come into place. And then you develop the program, like the design, the program, implement it, evaluate it. So a circle that I talked about, right? This is also, like when it comes to training the public health professionals in the EBPH, this is the same cycle. So, in every point here in the cycle 1 through 7, there are practitioners and experts working in those areas and then working together in concert in the cycle. Gonna skip this part. You can just read it. It's don't want to repeat. So now I'm gonna talk a little bit more about implementation and dissemination science. So that's the type 3 evidence we talked about. Remember this meme went around for a while. I don't remember when, definitely pre-COVID. So you see some like beautiful recipe or like even home improvement or whatever on Instagram, and you do it and you see pictures of nailed it, and then look at how different because you have different kitchen, you have different stove type, different gadget, and any little thing that is a variant from this Cookie Monster cupcake and the perfect form can make a difference in outcome. So can we say that do we say that the perfect Cookie Monster cupcake, something is wrong with the recipe? No. What went not so right is in the process of implementing the recipe, right? So figuring out what those may be, those steps and processes that that can be refined, so that every time you bake cookies, Cookie Monster cookies, you make cupcakes. I'm sorry. You make exactly what it looks like here. So that's implementation science. So, use data to identify the same thing. There's a repeat. Repeating is good because it's very important concept. And then you find evidence-based solution, adapted impact. So, here, right here, adapting for impact and preserving core, components while keeping the core components. So, for example, here would be the Cookie Monster's eyeball, the sprinkles, the blue sprinkles not melting. I don't know, like so those whatever we decide the core component of the program is, while preserving it, how do we adapt? Not just straight adopt, but adapt it so that we can get the result that we want. So test and learn. So this is also very much like, what does it look like? PDSA, right? So that's in theory. That's what implementation science is, and in reality. So if the theory is that, then we know that we should be doing these things. In reality, look at this: 7% of like there's millions of like different programs to prevent chronic diseases of different kinds. Like this is more about the eating, nutrition for kids, nutritional program for kids. Only 7 out of 100 were pre-developed program, as in like it's been pilot tested before, and then only 2%, 2 out of 100 are evidence-based. This is based, as of 2017 systematic review, and over 17 years of looking at these programs, only 14% was evidence-based. So in reality, like, I was saying in the earlier part of the lecture, being evidence-based is really difficult. So for so many reasons, having evidence is one thing, but actually implementing it to work for you and your program, your locale, all the more harder. So in reality, it's not really implemented very well. So these are the steps of, how you would go about adapting the existing evidence. And to do that, there's this thing called Hexagon. It's an exploration tool. You can find it. The reading is in the folder. National Implementation Research Network. So implementation is a research. Like there's a discipline within research that's called implementation. I just said information science many times. So need, evidence, fit, usability, capacity, support. So these are the things that it's a hexagonal tool to apply to look at a program to really understand how to make implementation work. And these are the, I guess, evidence evaluation guideline for implementation science. And there are many different frameworks. And I think because the field is relatively young, the implementation research field, I think that, these frameworks out there will be trimmed into different categories of what is a gold standard, what works better than the others. Right now, I mean, there's some we know that are well known and works well, whatever. But there are a lot of different standards. They're not entirely different from one another, but it's not quite standardized. One of the better known, one of the best known framework is called the EPIS, Exploration, Preparation, Implementation, and Sustainment cycle of it. EPIS framework is a well accepted and adapted framework for implementation science. You can go to their website down here to check out more. I'm not going to go through this, but I just wanted to point out EPIS. You may be hearing it when talking about implementation science, and this is where you can find it. Also, really quickly, the difference between dissemination and implementation. Dissemination science is a thing, it's a field, and then implementation science is different. They're related, but they're different. So first, dissemination science, hopefully it is what it sounds like. So studies, this dissemination science studies factors and strategies that lead to widespread adoption of EBP evidence-based practices into policy and practice among key stakeholders. So once we have an EBP, so getting the EBP established is the first step. That in and of itself takes like time and the whole discipline to do that. And then you want to be able to actually start implementing it. So disseminating the EBP itself to the decision makers for them to say, yes, let's do this. So that process, studying that process and how to do that effectively, how to do it in a culturally responsive and community engaging way, that is in and of itself a field, is dissemination science. Implementation science comes after that generally, not always, but because it works in a cycle, which I'm going to talk about in a minute, just like a lot of other things I talked about. After a while, you kind of lose track of what happened first, but generally dissemination happens first, and then implementation science is when the leaders decide to make the decision to adopt this EBP. And then you study how well you can implement it, how to successfully integrate it, and implement it. So they are related, but they are complementary, but they're not the same thing. So dissemination outcomes will be measuring then focused distribution of specific audience via determined channels. So how to like really from the EBP, establishing EBP to getting the agreement and implementing it. So the outcome will be different from implementation science outcome, which would measure effects of deliberate actions of implementation, details of implementation itself, specific to implementation strategies and choice. So, for dissemination outcome, change in attitude, you measure it. Like, when you go through the iteration of you're trying to convince the decision makers to adopt it, like what do you see in the change in attitude and behavior? How can we do better next cycle? Awareness, receipt, use of information, information/innovation, or intention or inclination to use innovation. And implementation outcome will be like once the decision has been made that you're implementing it. So, acceptability, adoption or fit, appropriateness of this, particular intervention, feasibility for this setting, fidelity, for, keeping the core element of the program, like how much fidelity can we retain while adapting the other things, inflation cost and sustainability. Again, it's not a one-time thing. There's almost no point of just doing it once, and it's all about continuous quality improvement. So that's how dissemination and information science are different. Again, adoption is influenced by, all this various external context and characteristics of EBP that influence the speed and extent of adoption are these things. Cost, of course, effectiveness, how simple is it? And how compatible is it with the others, suite of programs we have, or how compatible is it with their population? Can the change or improvement be observed? Trialability, can we trial this out and in the another similar settings? So the bottom, so this is it. Bottom chart is in linear fashion, but really it's also, it can be looped like cycle. This looks very much like a logic model you may have seen, right? So EVP is the what. So once you have to have the EVP established, that's again, whole thing, what, and then implementation science, implementation strategy is how, and then you get the implementation outcome, which mention what are the implementation outcomes. These are the implementation outcomes. And then service outcome, the actual service delivery. That's what in the logic model we called it output, and then eventually health outcome. And these things work in cycle, like dissemination usually comes first, and then implementation, but it goes in a cycle. So dissemination, adaptation, implementation, and then sustained and assess again, disseminate to hire different or like a bigger pool within the organization or the city or whatever, and the circle goes on. And this implementation science, like many things we've talked about already, participatory aspect is critical. So stakeholders, ongoing iterative approach to collaboration between researchers and stakeholders to improve the pathway from research to practice and create system change, improve health, and address disparities. Participatory is critical element of implementation science. It talks about there's an article that is in the folder that talks about continuum of engagement. I'm not going to go through this. You can look at the slides as you read the article, and you want to understand, like what kind of partnerships advance the research, what kind of partnerships to spread the findings, and how can we keep the participation of the stakeholders high and as close to real world relevance as possible. And a simple example I put here is a HPV vaccination pilot, and this also is very analogous to COVID or any vaccination actually. So on the left-hand side, these are the levels of different kinds of stakeholders, and this is from planning, executing, evaluating, sharing, scaling up. So it's a cycle, right? So planning to scaling up, so it goes in cycles. So what types of stakeholders are involved, where the X's are, So this is how you gauge, continuous and participatory implementation science. Again, HPV vaccination, we know it's effective. It's already that's the EBP, but we're talking about how to implement it in an evidence-based scientific way. And here's different databases to search for EBPs, and I just put it in here for you. And there's the web link here for you to explore. So it's really very, very high level of what implementation science and dissemination science is in relation to evidence-based practice. Every evidence-based public health, EBPH, EBM, all those EBP, they're just part of the whole community engagement and implementation of the program towards a successful outcome. Evidence is important. We said in the beginning how hard it is, right? So yeah, but that's the first step. EBP is the first step. That's the what, and the how, and then how much, and how you involve the community is a whole big circle of model that we got here. So it's really to expose you just a little bit into what these are, and I hope that this whet some of your appetite to look into more of this as you think about what public health management work that you want to get into, things like that. Thank you.